In a world of EMS podcasters, EMS Office Hours is the only live podcast bringing you the latest topics and opinions in EMS. Turn down your scanner and turn up your speakers as we join Jim Hoffman and Josh Knapp on their latest EMS podcasting journey.
All right, welcome to EMS Office Hours. It's Jim Hoffman. Dave, you there? I hear you talking.
Yeah, I'm there. Hey, welcome.
All right.
Everyone.
Yeah. Well, I had muted my voice as the intro was playing. So as we await Josh to call in and join us. Josh Knapp, the other guy.
I remember.
One of the other guys.
Right. Yeah.
The other guy that joins us in the weekly, well, the bi-weekly fray that is, podcasting.
Yep.
I want to remind people, of course, to check us out on Twitter at EMS Safe. Follow us on Facebook, and Facebook is facebook.com/EMS Office Hours. And to send us emails on topics you want to hear about or comments about the show or what one of us might have said during a show. And that email is contact@emsofficehours.com. And you can also go ahead and actually leave comments on the blog itself. You can leave comments here at Blog Talk Radio. There's all places that you can reach out and get in contact with us, and join us here on the show, or at least have your voice heard on the show. So, all different ways that we can do that. So, Dave, how have you been? I know it's been about 2 weeks now since we've been going on,
Yeah, I've been real well. Enjoying my time.
Yeah?
Yeah, good stuff at work. Good, some nice, exciting ambulance calls, non-routine stuff, which is always nice, something that challenges your brain. I enjoy that.
Yeah.
Because that's not what we do 90% of the time.
Yeah, I know. I guess that's some of the expectations that people have coming into this job, that they're going to have the, 2% of the calls that we get rather than the 98% of the calls that we get, So.
Yeah, most of the time we just help people out of awkward situations that we're good
at. Yeah,
at.
Exactly. Let me see if I get Josh in here. Looks like he might be in the queue. Josh.
Yeah, I'm in the queue.
Yes, I can see that. Well, now you're live with us.
For some reason, I'm having a lot of problems seeing the keyboard. Anyway, hello. How are you guys?
Okay. All right.
Seems like we're being plagued with technical difficulties this month.
Well, I was telling Dave, I'm not sure what's going on. I didn't have a chance to troubleshoot some of the audio issues like I wanted to before the show today. But hopefully during the week I'll tackle that. I have a brand new whiteboard that I have behind my desk that I have a list of things to do for the day and for the week, and I get to cross them out as I do them, so it's very exciting.
Yes. Well, that's one way of staying organized. I mean, in this business, you got to, right?
Yeah. So it's one of the little things I'm doing to help keep me on track and sort of see what's most important, on that. So.
Gotcha.
And we'll go from there. So, Josh, are you calling in through Skype, or are you calling from a phone?
No, I'm calling in through Skype. Can you hear me okay, or is there a lot of background noise?
Yeah. No, I'm just wondering, because you dialed in, I guess you dialed in, or did the click to listen or click to dial from your computer?
Right.
Okay.
But for some, and, you have that click one or press one for the host queue.
Yeah.
I am not able to see my keypad right now. The way for some reason I have a configuration issue right now. But we are here. You knew I was calling in. I was able to text you, so we're rocking and rolling.
Well, the reason why I asked you because in the queue you come up as Watnu and not some kind of random phone number.
Oh, great. Excellent.
So that's a good thing.
Hopefully we can start reusing the original platform, but Blog Talk seems to be not cooperating with you.
I'm not sure what's going on. So anyway,
how's your week been, guys?
How's the week been?
Mine's been wonderful, Josh. How about yours?
Mine's been insanely busy, Dave. I have exponentially kicked up my let me say my responsibilities.
Yeah, you went in there with eyes wide open, though, right?
That's an interesting phrase. When you talk to your students, do you think that they fully anticipate what they're getting into, even though you do a great job of describing what the job is?
No, because they filter it. Some of them actually think they can make a living doing this.
Fools.
What do you mean by filter it, though, Dave?
Well, they see it through the excitement. They think they're going to save lives, and I tell them they might, but as we said earlier, I think most of the time we help people through situations that have become routine for us, and which is good because when somebody else's heart attack, somebody else's stroke, it is routine for me. It's routine for you. And when somebody comes to help me, I don't want them saying, this is my first cardiac chest pain call. I've never done one of these before. I would like it to be routine for them. So I don't, I don't have a real adrenaline rush every time somebody else is,
right,
doing the routine thing for me. And for them, it's not a routine. I understand that, but
now when somebody's out there and they maybe have a few calls under their belt and, they're facing something that is routine, I mean, do you still want them to have the enthusiasm that they had from the initial call, or do your expectations that, as soon as the newness wears off, it becomes the same old road?
That's a good question. I don't know if the enthusiasm. Yes, but I don't think enthusiasm is necessarily what I want them to have. I want them to have compassion, empathy, and concern. I want them to really, really have that, and I want them to have that all the time. If they're enthusiastic, I would like them to enthusiastically provide care. I need them to be all charged up?
Doesn't enthusiasm help provide the other attributes?
No, I think enthusiasm provides adrenaline, which may or may not help you with everything else. Maybe. Listen, it depends upon who you are.
Well, sometimes, it's sometimes, compassion is something that is, I think, one of those good human traits, and is one of those things that we can pull out of our emotional toolbox in relating to other people. But I think that it is difficult to show, to pull out those tools and use them well without having some sort of, I don't want to say adrenaline-backed, motivation, but, I will say, I'll say enthusiasm. I think that you have to, enthusiasm to me says that there's a love of the job, a love of what the task at hand is.
Okay.
And, in order for that, in order to, use those other relating tools, you should be liking your job. And I think it's very difficult to show compassion if you don't like your job.
Well, I don't disagree with you, but what I was reacting to was what you were describing that the providers have on their first few calls, and I think that enthusiasm is a different level of excitement and adrenaline. I would like them to always be enthusiastic. I am happy to provide care. I can't wait to help you through your emergency that I have become routinely good at. But I think it's a different kind of enthusiasm, and I would like them to keep it. And I call that enthusiasm, compassion, and empathy, and maybe we're talking about the same thing.
Yeah, no, there was a reason I was asking that, because there's been this other sort of thread that Jim and I have talked about, which is the burned out medic. It's not necessarily burned out, but you've been there, done it so often that you just sort of have almost a flat affect when you approach a job.
You think it's from frequency that causes the burned out medic, or something else?
Well, maybe the wording, the exact phrase "burned out" is probably maybe either harsh or even wrong. But you get these guys who act like they've been there, done it a million times. And one of the threads that Jim and I have discussed is the new guy on the bus, who immediately cops that been there, done it, a million times, even though he hasn't really earned his stripes yet. And the reason that I'm sort of going with that is, what do you do? I mean, how do you feel about the guy who is, even if you want to go to the spectrum, that harsh spectrum of saying burned out, but still does their job really well? How do you feel about working with those type of EMTs or medics? You know the ones I'm talking about. Those are just like. I mean, I find it sort of hard to understand how they can do it well consistently, yet sort of appear to have no interest.
Maybe they just don't show it well. But if they're good at it, if they're good at what they do, are they still being nice to the patient? Does the patient think that they're the most important person on the scene? Do they feel that they have the 100% attention of that medic that you're describing?
Well, I think that's a good point. That's an excellent point.
It's not enough just to, be real good at giving meds and starting an IV and interpreting an EKG. It's not enough.
It's not enough to be technically good.
It is not enough to be technically good at that. It would be very good if you were also technically good at providing emotional. Listen, people, these are traumatic events for people.
Yes,
often
the worst day of their lives.
Yes, and part of what we're supposed to do, if we do our job correctly, having just finished a curriculum in this, is minimize their trauma with this. Give them back the control to their life. Make them feel socially connected. And if we're not doing that, we're not helping them heal. We actually perpetuate their stress, their post-traumatic stress from this stuff. And we have a lot to do to make sure that we don't do that, even though we limited their heart attack, even though we helped them heal, even though they watched us do a good job on a loved one. We have a responsibility to minimize their post-call stress. Mm-hmm. While it's happening, you prevent and mediate the stress. You can't stop all the stress. Gee, your arm is off. I'm going to make you feel good about that. No, you're not going to make them feel good about that. But you're going to make them feel cared. You're going to give them social support. You're going to help them plan. You're going to help them organize. This is important stuff. And if we do that for them, their trauma is less. And that's our job. And you can. I don't care if you do it and you don't care about it, as long as the patient thinks you do. That's what.
I mean, it's sort of interesting that you use that example of somebody, having their arm taken off, and you're saying that, you're not going to make them. What was the word you used? You're certainly not.
You're not going to make them feel good about that.
Right. But I sort of laugh because I can think of a number of times I've had some horrific things happen, and by the time we're arriving to the hospital, and the patient might be in full immobilization, and if they're conscious and mentating, they're actually, laughing about what's going on.
Oh, you've probably done a good job.
How many times have you like joked with the patient, said like, no laughing, this is serious stuff?
No, and the patient says no laughing.
No. You say, when the patient is
I don't tell them
joking around.
No, laughing.
I don't mean that seriously. I mean it in a sort of a humorous manner.
I create a humorous manner if I can do it.
Right.
We sing on my ambulance. we the crew and the patient. You think I'm kidding?
No, I don't. I've done that too.
Yeah.
I've done that too. Jim, where are you?
I'm here.
Oh, okay.
That's good.
You're just sipping your coffee, listening to the discussion, huh?
I'm listening to the discussion.
I'm walking through
the one thing that I was thinking of when you guys are talking, when you talk about that enthusiasm that a new provider might have, and then Josh, you talked about the attitude of a new person sort of having sort of a chip in their shoulder, feeling like they know it all, that they're already burnt, they're already tired of the common calls, that sometimes I think that enthusiasm or that attitude can come about when you've got the more experienced provider who is looking at the enthusiasm as a negative thing. So then that new person starts to feel, okay, well, I'm not being accepted, by being enthusiastic towards these calls. So let me go ahead instead and act like I don't care or act like I'm burnt out, so that I'm accepted by the more seasoned people. So I'm not being talked about in the crew room. I'm not being looked at like I'm this new jack wanting to save the world sort of attitude. And I think to some degree we end up sort of creating those monsters. We've been creating that attitude on our own because a lot of us aren't understanding of that new provider mentality where, yes, they're coming into it, not really realizing that every call they go to is going to be this life and death situation, and of course, being a provider for even a short period of time, you're going to realize that that's not necessarily the case. So as soon as a new guy comes in, even if you've only been doing it for a year or 2 years, now you're the old guy. You're the one that's been on the street for a year or 2 years or 3 years, and now you can look at them and say, oh my God, this guy doesn't know what he's in for. And then people tend to talk about them. Did you say something, Dave?
I didn't. I heard you disappear. That's all.
Oh, okay. So
I think sometimes new folks try to emulate the seasoned person that they're seeing, who's projecting calmness and maybe even boredom, because it looks like power. It looks like I'm so powerful. I've seen this so many times.
I'm very much in control. I'm bored.
Right. Nothing's going to rattle me. Nothing's going to, affect me. And
flat affect is not the same thing as control. Flat affect only mimics a little bit of control. It's not.
Yeah. So what do you do when you get on the bus and you have that, as a real seasoned guy who really truly has been, pretty much seen and done it all? What do you do when you're faced with that, Dave?
When I'm faced with what? I'm not faced with that. I have the enthusiasm. I love every response.
But when you're faced with a crew member who is sort of doing that, been there, done it all, and they really haven't.
You know, it's interesting. The people that I work with, for the most part, they're all charged up.
I forget you're in the golden world, volunteer.
I am. Although I will tell you that somebody from a place where you work has said to me, you know, Dave, if you were doing this on the city ambulances, they would call you an alarmist, and the doctors would stop listening to you, and the nurses would say, just go to triage.
Sure, there might be some truth in that, though, because you know, that does. I mean, I've seen that happen to people where you know you get the ED staff starting to look at people that get tuned through the ethic as being that way, you know. But I think the flip side of that is that if you're treating the patient appropriately and you're right in what you're presenting to the emergency department, then that doesn't happen, you know.
Right. But, you know, one of the things you have to do, I think you have to. We had a call recently where a person, I was rather suspicious for a head injury. It probably wasn't, but it was suspicious. And the person had a little bit of confusion. And I had called ahead and I had said to them, listen, I said, along with everything else we're thinking, I said, we're thinking about this could be a head injury. And I went in after we brought them in, and I said to the nurse, I said, under these circumstances, I don't know about you, but I would want imaging of the head. And then the medic said to me, he says, they're going to stop listening to you because you're an alarmist. He says, that's what would happen in the city. I said, you know, that's what you're supposed to do with these circumstances. You're supposed to think about the worst thing it could be. When you go, if a doctor goes the other way and says, you know, this is probably just nothing. I know what it was. It was drunk with a hit in the head. He's probably just drunk.
It's interesting that you bring that up because I was actually I backed up another unit last night, and they had there was a big party here in the park, big brew. A beer fest or something like that, or a German day. I don't know what it was. There was about 1,000 people in Lederhosen drinking beer. So call that whatever you want. But we had one guy who just, you know, he happened to be a fireman from overseas. The whole troop was there, and they didn't speak a lick of English. You know, a couple of guys were a little broken, and they were trying to attend to their pal, who was so drunk he fell face down on the sidewalk and with enough force to lose a tooth and put a good lack in his head. And I told the guys who were taking care of him, I said, because they were sort of taking their time bandaging him on scene, another guy was looking for the tooth, and I said, you know, keep in mind that the intoxes can trip you up. So, you know.
Which was exactly what I said. I said, you know what, this guy is probably drunk with polypharmacy, but he did get a smack in the head, and I was told, you know, he says, but he's not complaining of head pain. I said, well, with the polypharmacy and the alcohol, he may not be feeling, he's not reliable even about himself. So I had said that, and I told the nurse, and the guy said, you know, I had said they should do some imaging, and I left with one of your buddies, or at least somebody you know, and you know, we did the alarmist thing, and I said, listen, just because I tell them that doesn't mean they're going to get a CAT scan. I can't order a CAT scan. I said, if they order a CAT scan because I told them this, that's because it was the right thing to do. So he went back 2 hours later, and he had his head scanned. Because you look like a jerk if you don't. You look like a jerk. And nowadays
the liability of not making sure, and it's so common. It's such common knowledge that, you know, a head bleed is sort of an easier thing when you're an intox.
Sure.
That I don't see how a doctor could even turn around and shake their head. But it's a fine line. But, you know, it's a fine line of what, you know, that person that I may know or should know said to you, and being a patient advocate.
A terrific medic. A terrific.
Yeah, well, he works with works at my
works
place.
with you.
Of course, he's a terrific medic. But you understand what I'm saying. I mean, there's a fine line in some cases, and I understand what Jim's saying too. You know, as big as a city as where I am, you know, New York can be, the community can be very small. You know the triage nurses. If you have an area that you're serving, I mean, for me, it's less so because I tend to, work all over within our system, and I work in a fairly large system.
Because it's not fair to afflict you to any one area repeatedly.
Right. Yes, exactly. No, I'm just. Never mind. I'll stay away from that comment.
I hit the nail right on the head.
I'm going to stay away from that comment. But especially since I've been told now I'm actually beginning to do my CC ride-alongs this week, so I'm pretty excited about that. Yep.
Should be excited. And enthusiastic.
And enthusiastic. I am both.
Empathetic, passionate, and all those other good things.
Yeah. But where is that fine line? Where do you draw that line in the sand between an alarmist? Because even you could, I'm sure, have seen people who are alarmists, and that being the patient's advocate.
I don't know that you can draw the line. You have to. If you're thinking things that have no foundation, then you could be an alarmist. If you have no, and if you fail to treat people for things that can be really bad often enough, you will overlook some serious stuff. So,
but at the same time, I mean, Dave, you can't go into a call and do everybody's job for them either.
Right.
We're limited on what we can do in the field. And we're both in time, equipment, training, and when we hand off the patient to the emergency department, if it's like you said, you get an intox that hit their head, they should be doing the proper assessment and exams and testing and all that stuff. It shouldn't be up to us to sit there and tell them their job. Because you can rub them the wrong way by doing that. They can look at you as if you're trying to tell them to do their jobs, whether they were going to do it anyway or not. I understand what you're saying, that if they do it because you mentioned it, then yes, it's a good thing they did their job. But I think sometimes at some point too, there has to be that patient handoff.
Yes.
I mean, I've had partners that were so into what was going on with the patient that they're following up with the hospital, throughout the night. What happened? Where'd they go? What did you do? Did you do this? Did you find out this? At some point, it's on to the next call.
Yes.
We don't have that luxury.
But you do need to know what happens, because you can't validate your clinical judgments if you don't know the outcomes.
Well, that's a problem.
I would love to get feedback on I would like to know the outcomes of every patient I treat.
Well, I think we've actually talked about that. That's a broken part of our system, isn't it?
Yeah, not every place
I want to go back for one last thing before we move ahead. We can't both complain that people don't listen to us and then say we shouldn't tell them what we're thinking. It has to be both.
Well, yeah, but I think I think there's a balance on what you're telling them, what you're thinking, and to me that's telling them what you've assessed and what you found.
Yes.
I mean, I don't know all the tests that an emergency room is going to do on a patient based on what I tell them. I can assume that a patient is going to get a CAT scan or is going to get a blood workup, based on what I'm bringing in to the hospital. But there's other tests that might be getting done that I have no freaking clue of what that is.
Right, but you should be able to tell them what you're thinking is wrong with the patient.
Yes, and I agree with you. If you have a patient I mean, listen, I've brought in the same type of situation where you bring in an intox and they got a pretty good head injury, and you try to stress to the staff, listen, I know he's drunk, but he's got a pretty big, gash in his head, a pretty big bump in his head, and, try to stress to them that they shouldn't be blowing off the patient just because they're drunk. Or they shouldn't be, even with patients I've had that are homeless, that you see a patient that's homeless that's having a cardiac complaint. Don't blow it off as being because they're saying they have chest pain because they're going to get a free bologna sandwich. Sometimes they really are having chest pain. I mean, I've had homeless people that were in SVT. I've had them that were,
sure.
In
because
sepsis
being homeless
and stuff
doesn't
like that.
give you immunity.
Right, exactly.
Being homeless doesn't give you immunity. Right.
And
you know what?
This is something that goes back, I think, Dave, what we talked about last time, when you talk about the frequent flyers that get admitted to ICU because there's underlying things going on, and just because they're homeless or a frequent flyer doesn't exclude them from having a genuine, issue going on.
And by the way, if they need to go to the hospital because they want a bologna sandwich, give them the bologna sandwich.
Can we bring the bologna sandwich to them instead of bringing them to the hospital?
I would.
Can't there be a service
I wouldn't
that brings the bologna sandwich to you?
Bologna sandwich.
What's that?
I wouldn't begrudge them the bologna sandwich.
No, but can't we just bring the bologna sandwich to them instead of making them go take it to the hospital and let them get it there?
It's an expensive bologna sandwich. We know that.
Yeah.
Hey,
and
Josh, remember we had a meeting?
Frustrating bologna sandwich.
Josh, do you remember we had a meeting in New York City? You, me, and somebody else. We don't need to mention anybody else.
Yep. Yeah.
Do you remember what I told you happened while I was waiting for you at a Starbucks?
I remember that guy.
I gave him my gloves.
Right.
It was freezing out.
Yeah, and but that's you are a compassionate person. I mean, if
I have become quite the sap in my old age.
There's an aspect of on a freezing day giving somebody their gloves, and there's an aspect of giving them $20 to go buy gloves. If you give them the money, you have no idea what they're going to do. But if you give them the gloves, you have a good idea what they're going to do with it.
The only way they're going to turn that into money is to sell it to somebody else.
And the value is really not there.
Yeah. So.
I've known, but Dave, I've known people to take the coat off their back and give it to, somebody who needed a coat. And then, when people have asked them, they said, I can take a cab home to a nice warm apartment.
Yeah.
So, those are extraordinary situations, but but that's isn't that part of compassion?
It is, absolutely.
The thing is, though, with anything, you only have so many coats at home, too, to give away.
It's true. I can't take on everybody.
Yeah.
I do one person at a time. As much as I can.
Yeah.
Even if they have a bloody nose, even if it's routine.
Well, here's something, and this is something, Dave, you mentioned earlier, and something that I can kind of agree with too, is sort of giving the patient that peace of mind, and it doesn't always have to be the person that's having the heart attack or the person whose arm is cut off. It can be the one who's got the fever, or the one who's got the stomach pain, or who has a cut finger, or who's just having an emotional issue at that time, a psychiatric patient, and sort of having that enthusiasm for your job, where you can have that compassion and know that limited time you spend with them might have some sort of an impact. And I think it's understanding that it's that person's emergency at that time, not our emergency, but the emergency that they're having at that point in time. And I think that's what we have to sort of have to try to understand and come to grip with when we're doing the calls that are sort of nonsense. You know, the calls that we get that is very routine.
Yep.
Seems to be some background noise going on.
Yeah.
From me?
I don't. If you type, who's typing?
Oh, I type.
There you go.
Sorry.
Oh,
that's
no
all right.
problem.
I just want to make sure I wasn't going crazy.
Yeah.
Listen to the typing.
So, Jim, you know, with the and I know there's a sensitivity to commenting on your work environment because you're in a fairly new place. But, you know, what if I pose the same question to you? I mean, I'm sure you've been on the bus a number of times with the guy who acts like the salted, you know, been there, done it.
That's usually me.
Yeah, well, it is you. The trouble is, the difference is in your case, you can back it up with a few years under your belt.
Well, you know, sometimes I think, like Dave said too, my I guess my attitude or my projection of the been there, done that isn't really something where I don't care what's going on. It's my experience and my time on the job that allowed me sort of that luxury of identifying patients pretty early on that are sick, not sick. You know, I give you a story that a month or so ago we had a guy that was stabbed in the chest. And we get there, and there's a lot of hoo-ha going on, you know. Everyone's jumping around, and you know, he was stabbed, and this is how big the knife was, and you know, he's sitting there, and he's talking, he's on an army breather, and you know, I'm assessing him, and it got back to me later on that the supervisor on scene was questioning, you know, that I wasn't being aggressive enough and you know, doing things for the patient. And my response was, well, you know, if I got somebody stabbed in the chest, I want to be damn sure that they've got something to treat. You know, I'm not going to start putting another hole in their chest, you know, unless I'm damn sure that they need it. You know, and that's going to be based on my full assessment, not just what a pulse ox says, or not just what a length of a knife is.
So you're talking. I mean, you're talking about doing a needle decompression, right?
Yes, right.
So I've actually been. Wasn't yelled at, but I was
reprimanded.
Lectured. Well, it wasn't even. I was more lectured by a doctor who felt that prophylactically decompressing somebody with a possible chest wound, not possible, but with a chest wound, was advisable because there could be a pneumo that you can't detect. And, you know, okay. I sort of felt, and I didn't really want to go, you know, I mean, he is an ER doc, you know, and a trauma doc, and certainly has the luxury to do things like that prophylactically. But, you know, when we talked about it, we have a set of protocols, and certain cases, you know, a reasonable action can be taken if a condition presents itself. And in my situation, the condition clearly didn't present itself. So, you know, which is the, you know, even the shortness of breath, or a quote unquote sucking chest wound, or any of those other things, you know, that would dictate a needle decompression. He had certainly the trauma, but I don't think anything else dictated that.
And it's not to say you're sitting there waiting for you know, the late sign of a you know, tracheal deviation or anything like that.
Right.
But you want the other things to kind of come into alignment.
Meeting the dead sign. Not the late sign, the dead sign of
Yeah,
tracheostomy.
right. Yeah, exactly. But it's funny because my partner, who relatively, medic's been a medic for about 5 years, who was questioned and said, by the supervisor, and was like, what's with your partner? What do you think? What's going on? I just kind of noticed that he didn't seem too concerned about what was happening, on the scene. And my partner said, well, listen, I think he's a really good medic. I mean, I have no issues with what he's doing patient care-wise. And I think that the fact that he's from New York, he's seen this numerous times, and it didn't really affect him as you might have seen with other people that might not have seen, a patient who needed decompression. You know
right.
what I mean?
Mm-hmm.
And I said, listen, I said, you probably know this from me that most calls, I'm not going to get rattled on a call. The most you'll see me do is look at you and say, I'm ready to go to the hospital. That's my way of saying I want to leave now because I know this type of patient and I know what's going to happen at any minute, and I don't want to be back here alone if they die.
Yes.
So, and again, it's not that I don't care. It's not that I have a lackadaisy attitude about what's going on with the patients. I just think that, that experience is there where you can kind of tell the difference, of a patient that's sick or not sick, or you can have the experience of a patient that you kind of know, all right, they're not looking sick now, but I've had this type of patient before, and they weren't sick, and they became very sick very quickly, and I don't want that to happen again, type thing. You know what I mean? And, that's the benefit, I guess, of having experience and being out on the street and whatnot for a numerous for amount of time. But I think, like Dave had said, that can sometimes, and I can see that, I guess, that sometimes the way that I might appear on a scene of not being rushed and assessing my patient before I treat them can be seen as maybe being burnt or maybe not caring, but that's not really the case. It's just that I'm the type of person that I learned very early on as a paramedic is that I want all of the information before I start to treat them,
Mm-hmm.
because I don't want to do an intervention that isn't needed, and I don't want to do an intervention that might hurt the patient, even if it hurts them in the long run. Maybe I don't see that that happening.
Well, I mean, can you? Yeah, most of the stuff that we do is fairly benign. No?
Until you go to do something, like give a med.
Yeah.
Well, Dave, even in that case, I mean, unless you're overlooking an obvious allergy or a contraindication or something like that, let's say, for example, you misdiagnosed rapid AFib for SVT, you give some Adenocard, and you're not really hurting the AFib. You're not going to cure it, But that's what I'm saying is that, you give somebody some Narcan.
What if it's WPW?
Well,
that changes everything.
That does, but then that's a contraindication, isn't it?
Yeah, that your instructor spent a lot of time teaching you so that you can recognize WPW all the time. You probably can.
Well, it's kind of funny because every now and then I'll get a patient on transport who is in WPW or has it, and I'll see their EKGs and I'll say, that looks, familiar, and but I almost doubt it because it's such a rare occurrence. When you hear hooves, think horses, not zebras.
Yeah, don't go looking for zebras when you're in England and you hear hoof beats.
Yeah. Well, did you guys, either of you see my post on Facebook?
No, I haven't. I've been really.
I did it about a week ago, I guess, and I posted a normal sinus rhythm of an 18-year-old male, and I asked people what they thought of what did they think about this rhythm, and I had everybody responding that it was a STEMI, global ST elevation, right-sided this, pericarditis, everything under the sun. One person said normal sinus rhythm. Out of all the people that were looking at it.
You're a tricky man.
It's a little depressing, isn't it?
Well, I wasn't doing it to be tricky. I was trying to make a point to people that, if it looks like a normal sinus rhythm, that's what it is. Don't try to make it something it's not just because it's presented to you. Here I am presenting it on Facebook, trying to say, what do you think of it? And people are so conditioned, I think, on Facebook when they get asked what an EKG is, that is automatically an arrhythmia of some type, or ectopy, or STEMI, or something like that going on with the rhythm, and they start trying to figure out what it is, because they don't want to be tricked. You're not going to trick me. I know there's STEMI in there somewhere. That's why you're putting it up on here. No, I put it up on there, the normal sinus rhythm.
See, they didn't take Dave's class, because you can't just shout out STEMI in Dave's class, because he'll turn to you and say, okay, what leads? What part?
It's good when they know it.
Let me tell you something. I put the EKG up there, and people were like, global STEMI. I see ST elevation and this lead, that lead. And I love when people go, lead 2 looks a little strange to me. I don't know what the hell that means. But after a while, I started thinking, wait a minute, maybe there is a STEMI. I started second guessing it. So I'm looking at the EKG like, wait a minute, maybe I screwed up and didn't put a normal sinus rhythm up there after all.
One of the things, and everybody knows this, when you teach people new stuff, or when they think there's something new up there, they see it. I mean, when I get people in the 12-week class, and they're really honest, and they're telling me they're taking it for the first time. When I get done teaching them bundle branch blocks and how to recognize it, and I think I have a pretty unique way of doing it, a very simple system. But I warn them, not everybody has a bundle branch block. Most people don't. You can't go seeing bundle branch blocks everywhere now that you know how to,
But that's what happens, though. I mean, I did that. When I took my first class about bundle branch blocks and all, every EKG I looked at, oh, it's a bundle branch. Oh, I see. And after a while,
but it wasn't wide enough, right?
I had to stop myself. I was like, wait a minute, what am I doing? Every patient I have has a bundle branch block? Something's wrong here. I caught myself. I've caught myself in doing that. I mean, I've been in 12-week classes where the instructor goes around the room, and they go, okay, Jim, what do you see here, for a STEMI class? I'm looking at it, and it looks like a normal sinus rhythm to me. I don't see a STEMI, but then I'm like, wait a minute, we're in a STEMI class. I should say there's a STEMI someplace.
Right.
So
Aren't you teaching me that? There has to be one.
Right. So I'm looking at this EKG, and I'm like, but there's not really enough elevation here, in 2 leads, whatever. I'm like, wait a minute. So then I say, okay. At one point, I can't stare at the rhythm all damn day. I have to make a identification. Being in a class as a paramedic, I can't stare at the EKG all day. I have to make a determination. So I eventually say, all right, screw it. And I go, it's normal sinus rhythm. And when I say that, I can feel like my credibility as a paramedic and I get like this like chill up my spine. He's going to go, what are you, crazy? There's a STEMI and leads 2, 3 AVF. What are you, blind? Yeah. And he goes, absolutely right. It's normal sinus rhythm.
And you feel good again.
I feel vindicated. I feel, oh, thank God. I always feel like when I do that, I have a chance of screwing up later on because I got one right. So if I get the STEMI wrong,
whoever
later
the teacher was, that's exactly what, that's just great teaching, not showing people everything that's wrong. You got to be able to tell what's wrong in the context of what's not wrong.
There is the other side of that coin. When you have a bundle branch block and you see it, and let's say you think you have have you ever been deviated away from a STEMI center because the patient had an existing bundle branch?
You're asking me?
Either one of you.
Not me, because my receiving hospitals are all STEMI centers.
Okay.
I haven't been deviated away from it, but when I've sent the EKG, and I actually had a patient recently. There was so much shit going on with the EKG, I couldn't tell if I was coming or going with this rhythm. It looked like there was a STEMI, but at the same time, it looked like there might have been some LVH going on, and so I'm like, you know what? I'm sending this to the hospital. And they looked at it and they said, you know what, just bring it in here. We're going to work it as a STEMI in the ER. We're not going to bring it up. We're not going to go to the cath lab, but we're going to work it up in the ER.
Call the cardiologist downstairs.
Right, exactly. And that's what they ended up doing. And in the end, it wasn't a STEMI because as we were going to the hospital, the ER doc consulted with the cardiology doc with the EKG, and they decided it wasn't a STEMI. There was other things going on there, so they didn't, end up working it that way. But they didn't divert me away from that hospital to the closer hospital because just in case it ended up being a STEMI, now they're screwed because now the patient's in.
And that's why they have cardiologists.
Yeah. Yeah, I mean, listen, the like I said, I've had and then the 12 lead was saying consider STEMI, but it also like has all the other diagnoses on there as well, and I'm like, okay, you know what, this is out of control now, and and then you repeat the 12 lead, hoping you might get a different, cleaner reading on it.
What's the definition of insanity? Doing the same thing and expecting a different outcome.
Yeah, exactly. So. But I think, like you said there, I think you sort of, and when you're in classes like that, people anticipate that that's what they're going to see during the class, But I think that the classes have to, like that, it's also showing people how to tell the difference between the two things, Not just STEMI. You got to have the other things too, But so going back to what we were talking about, I don't think that having that sort of attitude of experience and confidence almost on the scene, sometimes it can be mistaken for not caring. It can be mistaken for being lackadaisy about what's going on with your patient, But the people that and the people that work with me know that that's the farthest thing from the truth, and that when I'm talking to a patient and I'm doing an assessment, my mind is in different places, figuring out what's going on with that patient that nobody's even either thinking about yet or nobody's even considered yet. You know what I mean? And the person that works with me is comfortable with that, and they know that that's the case. So that when I start treating the patient and I ask them to do things for me, that I've made a decision of what's going on with what's happening with that patient based on what I've got from my examination and vital signs and diagnostic tools. So.
You know what? Yeah, well, we have also had, all of us, I'm sure, the aha moment where we thought of something that was non-routine. Mm-hmm. You saw it, you said it, it turned out to be it, even though everybody, even the first group of doctors that were treating it, they didn't see it. And there's really nothing that feels better, in the sleuth mind of having done that.
Right.
You know what this is? This is Addison's. Oh, yeah. When was the last time you saw Addison's? Yep. This is it. I remember it.
Yeah, I remember when I was an EMT, and we had a patient that had a sub-Q going on. It was subcutaneous, and I'm listening to the lungs. I'm like, this guy is fitting the demographic, really thin smoker, and I was almost afraid to say it because I'm like, oh my, I don't think I've never seen this before, but I called it into the hospital and said that's what I had, and was kind of blown off about it, because you're calling in the hospital with a 20-something-year-old male, and and you suggest that that's what the patient has, and then you get there and they're all kind of looking at you like you're stupid, but then they have to listen to lung sounds themselves, and like, oh yeah, it's and then
subcutaneous is good for you,
right?
And
you feel like you feel
that.
vindicated, like you said, you have an aha moment. Okay.
Not only vindicated, it feels great.
Yeah, and you feel like, okay, what? I'm never going to hesitate in the future because now I know exactly what that sounds like on a real patient, what it looks like on a real patient. I'm never going to second-guess myself or have an emergency department second-guess me when I say that's what the patient has.
So let me, come back full circle to a couple of things we talked about earlier. In terms of being an alarmist, being an advocate, and making a difference. And it's sort of funny how, that making a difference thing, that thing that a lot of us have went into EMS initially to do, and then it sort of became that classic inside joke put down, why don't you go out and make a difference? But here is a perfect example of where you actually can and should make a difference, and the fact is that we're out in the ambulance to do exactly that. In those cases where we can intervene on the patient's behalf, know our craft, have a good skill set, and go out and call an early intervention when it's necessary. You in fact do make a difference.
Yeah,
I'll step off my soapbox.
And that feels good.
And that feels great.
And it lasts a good long time because it has to.
And it's sort of interesting. Yeah, right. Well put. I'll stop there.
Yeah, it has to last. Yeah, you're right. It has to last a long time. That's true. But I think at the same time, Dave, going back to something you said before we wrap it up tonight, when you talk about being the alarmist thing, that when you do say something like that to an emergency department, and they do find out that you were correct, they might have doubted you and either did the test reluctantly because now you put it in their head, or you call in a sub-Q, or you call in something like that, and they find out that you were right. That also builds your credibility. It gives you that cash, CACHE, you know what I mean? It gives you that with that emergency department. So the next time you say, hey, I'm coming in with a patient and, they've got a sub-Q going on, they're not going to question you. Or you say, I'm coming with a patient and I think they've got a head bleed going on, they're not going to question you,
Right.
Because you've built up that trust, that credibility with that emergency department. And that is where the difference between being called an alarmist and actually being called a good provider and an advocate for your patient is that sort of that difference there. The alarmist is where every patient's a STEMI and 1 out of 10 is a STEMI. Okay, you know what? Now let's just calm down now because every patient's not a STEMI.
Right.
The guy had gas or whatever. You know what I mean?
Right. Or even.
But if you call a STEMI 10 times and 9 out of the 10 is a STEMI, then you know what? Then you're not an alarmist at that point. Now you're a patient advocate, and now you're doing what's right for the patient. So there's that line there,
Now, for next week, we can discuss whether you give nitro to a person with pleuritic chest pain.
Yes, you do. Because you get tired of playing Columbo and asking 100 questions and you say, screw it, just have a nitroglycerin. It'll give you
Well,
a
there
headache.
goes next week's topic.
Have a binocular glass. Lift up your tongue. I'm going to give you a binocular glass.
If you have a headache, we've ruled it out.
Right. Well, let's walk you to the ambulance. If you make it, then you pass the stress test, and you're not having a heart attack.
But if you collapse in our arms,
right, then you were right. Right. Oopsie, you were right. You know.
Have you ever had a guy, or a woman meet you at the front door and be ready
with
to
luggage
go?
In their arms?
Not quite.
With luggage.
Well, ready to go to the hospital, and they walk out with you to the hospital, and they start telling you why they called an ambulance, and you realize halfway through the walk to the ambulance, this person shouldn't be walking.
Yeah.
Do you stop them right there, or do you let them take the 10 extra steps to step into the bus?
Well, it depends. That's a good question. I think that depends. If I think they can get up,
that's an opportunity also, right?
Yeah. That's a good question, because I've actually done it both ways. I've actually let them finish the trek to the ambulance, and I've actually stopped them and gotten the stretcher and all. And,
ABCs, ambulate before carry.
Yeah, but like you said, sometimes you get them and you realize.
But that's lifeguarding. That's lifeguarding.
Yeah, halfway. You realize halfway to the ambulance that they shouldn't be walking. That is true though.
Right.
So.
Yeah. So we've all seen it, and
the decisions
that we take to the field. Can you walk?
Yeah.
I think walk, but they get up, and they're not. By the time they reach the ambulance, they're not only short of breath, their lungs are gurgling. They didn't have that before.
But now you can treat.
Probably. Yeah, that's heart failure. Yeah, you got it. Good test.
Right
now, the ejection fraction is 35%.
Right. Thank you for confirming my differential.
Right. I was suspecting you had congestive heart failure. Now I'm 100% sure. Have some CPAP.
Yeah, right.
Now I can fix it.
Yeah. Now I can do something.
Let me put this mask on you. Can you carry this oxygen tank the rest of the way?
Tank. Yeah. All right. When we stop there, guys, if we mislead the audience thinking we really don't care by making these jokes. Of course, we're just joking. So, appreciate you guys joining me as usual. Anything you want to mention, Dave, before we go?
No. This was a pleasure. What's new in Wantanooland?
I still have the Palm. It's still selling, and it's still at the introductory rate. So if somebody's listening to this, you better move on it, because these supplies are limited, and once the main shipment comes in, the price goes up.
Go check it out, wando.com. Right there on the first page, you can go get it.
So are you suggesting that maybe right now would be a good time for a bulk order so we could resell them at a better price?
At the higher price, yeah.
You know what? I am not against people being self-starting entrepreneurs, and if they feel that they can do that, which they probably could, feel free.
Product. Listen,
in fact, contact me. There are further discounts on bulk orders.
That really is not that bad of an idea, because sometimes people could buy, let's say, 10 of them, and then go to the garage and sell them for another $5 more. And when people see it in person, it might be a different thing than just seeing it on a computer screen.
Yeah, like my tickets to the Eagle concert.
Yeah. So it's something to be said about that. So,
Wait, you're going to an Eagles concert?
No, I was gonna go, and then I let somebody else go in my stead.
Jones Beach Theater?
No, this was in the city. It was last Thursday.
Yeah.
$275 seats.
Nice.
How much?
$275.
Where? What venue?
I think it was the Garden. Maybe I'm wrong, but no, doesn't sound. Right.
I have no idea. I wasn't even. I realized I have the internet in front of me. I could probably look it up.
Yeah, it's not that important.
Yeah, exactly.
I was told it was an awesome concert.
Yeah, well,
The Eagles.
Yeah. But 30 years later than when they first started, so.
And they're just as good. I saw them a few years ago. Awesome.
Oh,
awesome.
Really? Okay.
Yeah. All right, guys. When we end it there, we shall see you in 2 weeks. We'll be back with another live show that time.
Excellent. Sounds good.
All right.
I'm
Have a good
looking
week,
forward
guys.
to it. You too.
All right.
Hey, don't hang up afterwards.
I have to hang up.
Yeah,
Okay.
we called into the show, but we can
Okay, yes,
do
you
a
do.
Skype
Okay.
thing. Okay.
Yeah. All righty. Have a good week,
All
guys.
right.
Bye.
Bye.
All right, everybody, that's it for tonight's show. As always, any questions, comments, concerns, be sure to send them over to me. It is contact@emsofficehours.com. Until next week, as always, Jim Hoffman, stay